Good morning, ladies and gentlemen. It's really a pleasure to be here this morning. And as a non-cardiologist, I would like to give you a perspective of what we as a gastroenterologist do once you decide that a patient who comes complaining of chest pain has actually no cardiac origin of his pains. For us, sort of the non-cardiac chest pain would be defined as a patient who doesn't have any angina, meaning that this patient doesn't have the typical retrosternal pain that is precipitated by exertion and alleviated by rest. And there are no objective evidence that this pain is due to ischemic heart disease. From our perspective, what we would like here to do is these are patients who come with recurrent chest pain episodes that are located substernally and are not caused by cardiac, musculoskeletal, pleuritic, pulmonary, or other disorders outside the GI tract. So we would like to focus on this group of patients when we clarify the mechanism of what's going on. I would like to put this in a perspective, in a sort of a cascade. Usually when patients come with chest pain, the most important point is really to make sure that there is not a cardiac cause, and this may be actually found in about 70% of the patients, leaving about 30% of the patients who may be having some esophageal origin pain or some, if you want, non-cardiac, non-esophageal, meaning they may be having some pleuritic pain, some musculoskeletal, or some functional pain in the end. What I would like to focus now on is a little bit on the mechanisms of what we, from a gastroenterologist perspective, go about when we talk about the non-cardiac chest pain, what kind of diagnostic tests we employ when elaborating these patients, and what treatment options do we have for this group of patients. In terms of the stimuli that may be perceived as esophageal pain or retrosternal pain, there is for sure the gastroesophageal reflux being the main culprit or the main cause of non-cardiac chest pain. Then esophageal distension may be provoking the sensation of pain in this area. And we may also have some abnormal esophageal contractions that could be occurring and ultimately causing the retrosternal pain. In terms of the acid culprit being the cause of retrosternal pain, this was one of the early, really 1950s studies where Bernstein first proposed a clinical test to infuse acid into the esophagus and see what happens when you elect pain and measure the time, how long it took for the infusion until the pain was reported. What was also shown later on is that sort of it's not only the highly concentrated acid, meaning a 1 to 2 pH values, but also when you go into a more, what we call as gastroenterologists, non-acid ranges of a pH somewhere between 4 and 6, that you may be still having pain elected, not in all patients, but still in a very important number of patients that would be having these pains once liquids with a pH, as I mentioned, between 4 and 6 are getting into the distal esophagus. There was also a question then, well, how reproducible are these acid perfusion tests compared to the normal to the normal events that occur during a gastroesophageal reflux episodes. And here Richter and colleague looked at 75 patients who were having this non-cardiac chest pain and compared the positive response to the test versus the abnormal acid monitoring or the method to define reflux disease. What they found was that this acid perfusion test was very specific, but had a poor sensitivity in diagnosing non-cardiac chest pain. So acid perfusion may be specific to reproduce reflux as cause of retrosternal pain, but not very specific. The next point was to look at balloon distension. So the idea was that if it's not acid in some of these patients, maybe just a simple distension of the esophagus may be the one who's producing these pains. The problem with the balloon distension is that the stimulus is not very specific, meaning that a distension of a balloon in the esophagus could be reported by some patients as pain, while others may be reporting some burning sensation overlapping with heartburn. That again, the site of the distension is also not very specific for the non-cardiac chest pain, meaning that you can elect non-cardiac chest pain, but it's in the proximal as well as the distal esophagus. And this balloon distension test showed that these sensations can occur independent whether you have lesions or not in the esophagus, mainly erosions as part of reflux disease. So another group from Denmark now tried to combine different modalities to elicit these non-cardiac chest pains and wanted to look at interactions between acid, distension, thermal, or electrical stimuli. And they used this multimodal probe where you could use actually an acid infusion port, the balloon distension, thermal stimuli, and an electrical stimuli to see on how these symptoms can be elicited. What they found was that a simple balloon distension had probably the same profile in healthy volunteers compared to non-cardiac chest pain patients. But what they noticed was that after infusion of acid in the distal esophagus, patients with non-cardiac chest pain reported the sensation at much lesser volumes than healthy volunteers, suggesting that in these patients there may be a co-effect of acid infusion and distension of the balloon. Of note is also that in these patients, the area where they reported these pains was much larger compared to a group of healthy volunteers who had a significantly smaller area where they were locating these pains induced by balloon distension with or without acid infusion. So these are nice mechanistic studies looking at different possibilities or clinical investigations that can be done, but these are now the things that we do in routine clinical practice. And here I would like to go through endoscopy, the esophageal manometry, pH monitoring, and what's very frequently employed is this trial of proton pump inhibitors, the PPI trial. When we are asked to do an endoscopy, these are the things that we're looking after. We're trying to see if the patient has any erosions in the esophagus that are indicating of reflux disease. Here you see the grading that we use from a Los Angeles Class A to Los Angeles Class D, depending on how much erosions you have in the esophagus. In some patients, we may not be seeing these typical erosions, but what we may be seeing are these furs in the distal esophagus, like train tracks that are like these train tracks in the esophagus. And if you biopsy these small whitish lesions, what you may be seeing are infiltrates of eosinophils indicating of an eosinophilic esophagitis as cause of the pains. But what happens in clinical practice again is that in most patients, what we find is a normal upper GI endoscopy, occurring in more than 70% of these patients where we don't find any lesions. So the next step would then be sort of to look at these contractility patterns as suggested by manometry. Manometry measures pressure in the esophagus from the proximal esophagus through the tubular esophagus, lower esophageal sphincter, and proximal stomach, and we get these pressure curves. Now, these are hard to interpret, so that's what we use. We convert this into these two-dimensional spatial temporal pressure plots, where we now can see the upper esophageal sphincter, lower esophageal sphincter, and we can actually visualize nicely the esophageal contraction as it occurs from the proximal into the distal esophagus. Where is it useful in clinical practice? Well, in some patients, we may be seeing these simultaneous contractions in the distal esophagus indicative of esophageal spasms. We may be seeing very weak contractions indicating of an ineffective esophageal motility, or we may be finding these repetitive high amplitude contractions in the distal esophagus suggestive of a nutcracker, or if you want, a jackhammer esophagus, which by these shear contractions could be the cause of the pains. What do we find in these patients when we studied them regularly? This was a seminal study in our sort of, if you want, esophageal GI part of non-cardiac chest pain. Phil Katz studied a group of 910 patients that where cardiac origin of their chest pain was ruled out by angiography, and these were wheeled pretty much from the cath lab into the manometry lab of the same hospital. What they found was that in almost 3/4 of the patients, the manometry was normal, whereas in about 1/4 of the patients who had an esophageal abnormality. This high amplitude contractions, this nutcracker esophagus was one of the causes, the ineffective being the other ones, and what a frequently sought diagnosis of esophageal spasm made only 10% of this group of 28%, so roughly about 3% of the patients who come for these non-cardiac chest pain evaluations. What we also do next is sort of to monitor for reflux. We can look at only pH monitoring of the distal esophagus to identify acid reflux. These days we can use a combined impedance-pH monitoring system where we can detect volume movement, where we can detect fluids coming to the esophagus, and we can in summary define acid as well as non-acid reflux episode. Why is this important? This is important mainly because in patients who come with non-cardiac chest pain and are on PPI, these non-acid reflux episodes may be the more important role and maybe the more important episodes that would cause or be associated with the patient's chest pain. Which test should be done first? I've shown you a couple of tests and I'll show you also a couple of empirical treatments. A group now here took a set of 42 patients, 18 males and 24 females, who had a negative technetium test amoebae test as the rule-out test for non-cardiac chest pain. And these patients underwent endoscopy, manometry, esophageal pH monitoring, and then were embarked on a double-blind PPI crossover trial over 28 days with a 21 days washout period in between. What they wanted to see is the prevalence of abnormal findings, respective the positive symptom response. What they found was that this objective testing were revealing abnormalities about a quarter of the patients with regard to endoscopy, manometry, and in about 40% with regards to pH monitoring. And the PPI trial was actually positive or indicative of reflux being cause of non-cardiac chest pain in about 71% of the patients, making the argument that probably a PPI trial would be the best first step test, if you want, or treatment modality for patients who come with non-cardiac chest pain. There's also a big meta-analysis that was published now almost 10 years ago, looking at 6 randomized controlled studies on the sensitivity and specificity of this PPI trial to diagnose reflux. And what they found again was that the PPI trial was having a high sensitivity and fairly good specificity to identify reflux disease as cause of non-cardiac chest pain compared to a placebo, which had a very poor sensitivity to do that. So how do we, if we put this in an algorithm, to give you an overview of what we consider, how we approach patients with non-cardiac chest pain, is if they have alarm symptoms, meaning dysphagia, weight loss, or signs of anemia, then what we would do, we would do an upper GI endoscopy, and if we find any mucosal lesions, we will treat them accordingly. Patients who don't have alarm symptoms, it's okay to go for an empiric treatment with PPIs. Here we usually recommend a double dose PPI for about 2 to 3 months, and then if the patient responds, then titrate the PPI dose to the symptomatic level. Patients with negative response to PPI, here we advocate doing a manometry, and again, if we find abnormalities, treat them accordingly to what we find. And if we find a negative study, then sort of have an impedance-pH testing that we can do on PPI therapy, and here we can treat if we find non-acid reflux, or if we find no association, then treat this as a non-cardiac, non-esophageal treatment. I would like to summarize quickly sort of the treatments that we have for these patients with non-cardiac chest pain. And here, the first one was, again, sort of an empiric treatment of Omeprazole versus placebo in a double-blind, placebo-controlled study in 34 patients with non-cardiac chest pain. What the authors found here was that the patients with Omeprazole had far fewer days without chest pain compared to patients who were receiving the placebo treatment, also compared to the baseline. Also, the subjective overall patient's assessment was better in the patients that received Omeprazole 20 milligrams twice a day compared to the patients who received placebo, making the argument that, again, a treatment with PPI may be alleviating the symptoms for non-cardiac chest pain. Again, here are also a meta-analysis. It's very interesting to see that from 244 papers, sort of the mainly of them were position papers, commentaries, and letters, and all other studies, leaving down to 9 studies that were able to be included in this meta-analysis, which met the scientific criteria for a double-blind PPI-controlled study. And in the treatment studies that actually included PPIs, there were 7 trials. All of them, with one exception, showed a symptom improvement on the PPI compared to placebo, leading to about a number need to treat of 3 to alleviate symptoms of non-cardiac chest pain. The other question was also if we don't find reflux, and especially if these patients sort of are having, if you want, non-cardiac, non-esophageal pain, could we use SSRIs, SNRIs, or tricyclic antidepressants as visceral analgesics for these patients? You may be familiar with studies published by Vardia and colleagues looking at Sertaline in a double-blind, placebo-controlled study, which actually nicely showed that with the active treatment, the intensity of chest pain was much less on the active treatment compared to the placebo, that the overall well-being assessed by an SF36 questionnaire was also significantly better in the group of patients with sertraline compared to placebo, but the Beck's depression index remained the same. So these medications are not acting by really their antidepressing effect, but more as a visceral analgesic modulator. Also, a group also clarified the effects of Citalopram, another SSRI, for esophageal hypersensitivity, and here they took a group of patients with known visceral hypersensitivity of the esophagus that were again randomized to receive placebo or IV Citalopram in a double-blind crossover study. This was an experimental study where they did manometry, balloon distension, and acid infusions, and what the authors here could show was that Citalopram really increased the threshold for initial perception and for discomfort for balloon distension, as well as for the acid infusion. Again, here making the point that these medications act as visceral analgesics in the periphery and in the esophagus and are not providing their effect based on the antidepressant effect. Tricyclic antidepressant, here is also a study looking at the effect of imipramine on esophageal sensation. Again, a rather small study in healthy volunteers that received imipramine in a slow increasing dose over a period of 12 days. And what the authors here found was again that the pain threshold in patients receiving imipramine was significantly higher compared to the times when these volunteers were receiving placebo. Again, making the argument that also tricyclic antidepressants can be used for modulating this non-cardiac chest pain. This is maybe it's, I know for cardiology sessions it's always very small studies, but still has the advantage that it's systematically reviewing how long can you treat these patients with tricyclic antidepressants, especially trazodone or imipramine. And when this group looked their chart review and looked over an interview over a period of 2.5 years on the patient's symptoms, they found that from the patients who had a functional chest pain or a non-cardiac chest pain that were initially treated, about 81% responded favorably to the treatment. And of these patients, 57% of the initial patients were able to be sustained on these therapies for non-cardiac chest pain, with only a minority of patients discontinuing this treatment due to side effects or failure to comply to the medication. So again, making the argument that this kind of medication, or this group of medication, can be used also with a certain length of therapy in patients with non-cardiac chest pain. This is probably one of the more solid and more serious documented patients that looks at also patients with functional, this time is functional heartburn, but could also infer from functional heartburn to functional chest pain. A study from Korea looking at an interventional double-blind placebo-controlled crossover trial in patients who had a normal endoscopy, normal manometry, and normal pH monitoring that were still having this retrosternal discomfort sensation between heartburn and chest pain. They were randomized to receive either venlafaxine, that's FX or 75 milligrams, or placebo every evening for 4 weeks. And the authors here looked at the symptom intensity scores, at the Beck Depression Index, and at the SF-36. What they found was that in the group receiving the active medications, a majority of patients had a symptomatic response, majority of them to about 50%. What was also interesting was that when they received the active drug, the symptom intensity decreased, which was not the case when they received placebo. And again, in the crossover group, again, the same, when they received placebo compared to active drug, there was no difference. So in summary, what I wanted to go through is sort of to give you the perspective of the mechanism of non-cardiac chest pain from an esophageal perspective, and that is mainly the reflux disease, distension, and abnormal contractions. In terms of investigation that we do to these patients or with these patients once they are referred as not having a cardiac cause of their chest pain is a PPI trial, the endoscopy, especially when they have alarm symptoms, manometry, and the pH monitoring, and the treatment options for non-cardiac chest pain would be PPI therapy in the first line, and patients who do not respond or who have other causes then try these visceral analgesics as SSRIs, SNRIs, or tricyclics. Thank you very much.
Thank you. Thank you very much, Dr. Tutuian, for this interesting talk on non-cardiac chest pain. Dr. Baer.
Thank you, Radu. Beautiful overview. There seems to be a direct link between vagal stimulation by reflux and the coronary blood flow that seems to be lower than by 20 to 40% in some studies. Can you extend on this? Because then it may not be right to differentiate the two diseases.
Yes, there are some studies suggesting that you may be having really what's called a reflux cause angina, that you may be getting this distension and sort of then you may be getting these things. But what I've seen so far, these are limited to mainly short series or case studies that really show that this is really clinically really relevant and leading to this kind of disease, at least sort of from my esophageal perspective.
Would you like to make some comments as well on other non-cardiac chest pains? This was the gastroenterologist's view, but you also might have some differential diagnosis in your discipline not related to gastroenterology for chest pain.
Well, I think that for sure sort of you can have sort of the musculoskeletal chest pains, the pleural, the pulmonary origin of the pains. These are really other causes that what we try is really to focus on sort of on our part of the investigations. That what we try to see if we find in the GI tract any cause of that. And again, here you may be having, depending on the presentation, if they are associated with dyspnea and that they may be getting pleural causes or mediastinal causes. Otherwise, sort of, if you have musculoskeletal problems, then they may be getting sort of movement associated or sort of, if you want, from the vertebral column causes of their pains.
Any other questions from the audience? So then I would like to conclude this session. I would like